Thank you, Narendra, for inviting me and asking me to deliver this talk. And good afternoon, everybody. Good afternoon, Dr. Balbi, Dr. Mulasari, Dr. Sanjeev. So, what this session is it about, as Narendra has already told us, it's about invasive imaging, and it is following a session on non-invasive imaging, a very good session, CT imaging and PET scanning and SPECT. But now we have extended this imaging into our cath lab. And so by intravascular ultrasound, by OCT. So today, what I shall be telling you, the topic allotted to me is how to interpret the basic image by the optical coherence tomography. So I shall be basically taking you through the journey through the catheter, small catheter of optical coherence tomography. But how did it all start? If we see the development of imaging, invasive imaging, it started as early as 1958 with an angiogram, coronary angiogram. But the limitation of coronary angiogram was that it's just a luminogram. It's a two-dimensional luminogram. It doesn't cut tomogram. It doesn't give us any information about the tissue characterization of the wall, of the plaque characteristics, which was later made available by the arrival of intravascular ultrasound in 1988. And this ultrasound uses sound technology. And the resolution of that intravascular ultrasound was 100 microns. And it's later, and the arrival of intravascular ultrasound has revolutionized the coronary stenting procedure, especially the left main intervention, especially the stent thrombosis patients, and especially the ISR patients, where the role of intravascular imaging is immense. But it is after the arrival of optical coherence tomography, which has been a game changer just because of its very high resolution of 10 microns. If you remember, the red blood corpuscle is about 7 to 8 microns. So you can even see large macrophages, you can see cholesterol crystals, you can, short of doing a histopathology inside the cath lab, what I say this is an optical histopathology, which you can do inside the lab in a patient who is alive and healthy. And you can take instant decisions on the table. So as unlike IVUS, OCT uses light wave. And let me first set the stage that how do you interpret an OCT image? There are three components of OCT image, which makes the image bright or dull, or one is backscatter, one is attenuation, and one is texture. So all the images are interpreted under these three headings: backscatter, attenuation, and texture. Now let me explain to you what do you mean by backscatter. Now backscatter means it is basically the reflection of the signal. Now I'll explain all these three terms, backscatter, attenuation, and texture, by a same group of two images through the coronary. Now, so backscatter means reflection of signal. So here you see that the signal is reflected back very, very greatly. There's a great reflection, very good backscatter. So this is a signal-rich tissue, signal-rich image, I should say. As compared to the image on the right side, where you can see that the reflection is not as sharp as on the left side. So this is a low backscatter. So this is high backscatter, it is low reflection. So I'll tell you what these images mean. Then come to attenuation. Attenuation means reduction of amplitude of signal as it goes. Here, suppose here is the OCT catheter. This is the OCT catheter. And as the light waves emit, so how much signal is lost because of absorption. So here you can see there is very less signal loss. It's signal rich, so very low attenuation. While here you can see that signal is lost, so this is high attenuation lesion. Now texture can be homogeneous or heterogeneous. Here you can see this is a homogeneous signal. while here you can see heterogeneous. So the same image, you can see three characteristics, which is backscatter, high backscatter or low backscatter, attenuation, which is reduction in amplitude of signal, high attenuated or low attenuation, and texture, homogeneous and heterogeneous. So this is the basic characteristic of OCT image interpretation. So this is, if we plot this backscatter and attenuation on X and Y axis, you can see that calcium is very low backscattering and low attenuation. It is low backscattering, and like this is a calcific, it is low backscattering. It is not as sharp backscattering as this one. So low backscattering and low attenuation. It is not attenuated. The light is passing through this. It is allowing a light to pass. As compared to fibrous tissue, this is fibrous tissue. This is low attenuation. It is not attenuating the light signal, but it is very highly backscattering. It is very, very bright picture. You can see the lipid. This is very high attenuating. You can see this lipid, which very, very highly attenuating. The light signal cannot pass through the lipid. So this is how we characterize fibrous tissue. We characterize the calcium, and we characterize the lipids in the OCT. So now this is the basic golden tube of the OCT, and you can see this is the catheter, imaging catheter. This is the wire artifact, 014 wire on which we thread the OCT catheter, dragonfly catheter. And this is the golden tube, characteristic telltale three-layered, normally looking, normal intima, media, and adventitia of normal coronary arteries. So let me start with describing a normal coronary artery. Now then, as you see that normal, this is the catheter, this is the guide wire, and there are three-layered, tri-layer appearance. First of intima, which is, you can say, high backscatter, signal-rich layer, unilayer, followed by a media, which is signal, low signal. It is an attenuated because it is composed of smooth muscle cells, followed by a heterogeneous mass of high backscatter adventitia. So intima, media, and adventitia. This is as close to the histopathology which you can do, intima, media, and adventitia. So OCT has this advantage, unlike intravascular ultrasound. The OCT's resolution, as I told you, is 10 microns, unlike the IVUS resolution, which is 100 microns. So IVUS cannot characterize so nicely about the intima, media, and the smaller aspects of that. So coming to putting all those three characteristics into different tissues now. So this is a fibrotic plaque. So first it is highly backscattering, so signal rich. It is low attenuation. It is not, there is no much signal loss as the light traverses. So it is low attenuation, and it appears homogeneous. It's not heterogeneous. So this is fibrotic plaque. And unlike this, the calcified plaque is, you can see this is heterogeneous, and it is well delineated, and it is low attenuation. It's not very high attenuation like lipid, because so the light can penetrate, and you can even see the posterior or the distal margin of the plaque. Unlike IVUS, in IVUS there is a shadowing, acoustic shadowing, because the sound waves cannot penetrate the leading edge, and there is an acoustic shadowing. And here the OCT scores very much over the IVUS, because in calcified lesions, and now with the arrival of different plaque modification tools like IVL or ROTA or orbital, now it is more important for you to characterize the plaque, whether it is concentric, what is the thickness, which you cannot do with intravascular ultrasound. And OCT, with OCT, you can very well define all those characteristics, which I think Dr. Balbir will describe in detail. And third most important is the lipid. And this is a highly backscatter, but very greatly you can see the light signals cannot penetrate beyond it, and it's dark, and it is, the borders are very diffuse. It's not sharply demarcated as in calcium. So high backscattering, very greatly attenuated signal loss of and diffusely bound. This is the lipid. So atherosclerotic plaque, as I told you, is you may or may not see the external elastic lamina. External elastic lamina is at the outer border of the media, at the junction of the media and the adventitia. At the junction of intima and media is the internal elastic lamina. Most of the calculations of the stent diameters are used by calculating from external elastic lamina. This is the external elastic lamina. So fibrous plaque is highly backscattering and a relatively homogeneous tissue. These are the few pictures of fibrous plaque, and there may be a lot of combinations. If the plaque can be fibro-fatty, you can see this is a homogeneous tissue, and then here it is a signal loss. So this is a fat or lipid. Here you can see calcium. This is a very circumscribed, greatly circumscribed signal loss attenuated picture of a calcium, which is heterogeneous. Then you can see the red thrombus and white thrombus. I'll come to that later. Now you compare these images where you can characteristically differentiate white thrombus, red thrombus, calcium, and you can, if you have done the IVUS, just see, you cannot see categorically where precisely the calcium depth, what is the depth of the calcium. You can't be very sure because of its lowest resolution is only 100 microns. So here the plaque and tissue characterization, the OCT scores much above than intravascular ultrasound. You can even see the cholesterol crystals. Now cholesterol crystal is a very highly backscattering image with no shadowing. And unlike macrophages, which has a punctate shadows behind them. And what is the importance of finding this? That is how you differentiate whether this lesion is the lesion, culprit lesion or not. A lesion causing, it's a vulnerable plaque or not. A plaque having macrophages is a vulnerable plaque. It's an, it may have caused the event.
Sorry to interrupt, sir.
Yeah.
Please, the time is up. You need to conclude now, please.
Okay. So, in the next few minutes, I'll be concluding it. And there is a very good correlation between the OCT and the histology, if you can see. The fibrous plaque, calcium plaques, and all, and the lipid-rich plaques. So, these are the basics of, I will not go into the detail. I've already explained to all this. Now, the red thrombus and white thrombus, you can differentiate from OCT. Similarly, the plaque erosion and plaque rupture, you can differentiate from the OCT. So OCT is of immense value, but you should be aware of the artifacts. The first artifact is inadequate preparation of the OCT catheter because the blood is basically swirling around. So you have to first have a blood clear field if you have to have a good image. And you have to also basically rinse your catheter purge your catheter very judiciously, because if the blood is in the sheath, then there is a acoustic shadowing because the light cannot penetrate this blood into the sheath. And this is the artifact because of the motion of the wall. So you should be aware of these artifacts, and you should not call it a ruptured plaque. So you should be aware of, and this will come by the experience. So ladies and gentlemen, this is the basics of image interpretation. The more you do it, the more you will learn. And so it is easy to use and interpret. The learning curve is much less than the intravascular ultrasound. And I would, in fact, I would advise you to use more and more OCT, especially in your acute coronary syndrome patients, especially in your stent failure patients, especially in your left main bifurcation stenting and calcified lesions. Thank you very much.
Okay, so I think what we can do is go on to the next lecture so that we can take the questions at the end. So maybe we can go on to the next speaker. Thank you, Nishit, for a nice lecture.